Dysphagia Rehabilitation Examples, an SLP's Guide to Dysphagia Assessment and Rehab. Where do SLPs actually start when it comes to dysphagia rehabilitation? Obviously, this is a very broad question, and the real answer is, it depends. It depends on the patient, their diagnosis, their desire to participate in therapy, and the physiologic impairments noted on their swallow study, just to name a few. In today's video, I'm going to break down the evidence-based steps that should be considered when assessing and treating dysphagia patients. And if you stick around until the end of the video, you'll get a free bonus that will help you gain a much deeper understanding of dysphagia exercises and how to use them with your patients. Let's dive in. I'm Theresa Richard. I've been a medical speech pathologist for 15 years. I'm a board-certified specialist in swallowing and swallowing disorders. I'm the founder and CEO of the MedSLP Collective and MedSLP Education. The clinical swallow exam. Let's talk about the steps of a clinical swallow evaluation, or the CSE. Before you even enter the patient's room, the first step is to thoroughly review the medical record, speak with the doctors, nurses, and anyone else from the medical team if indicated. Next, take a thorough history from patient and caregivers. This could include administration of an interview or a questionnaire that addresses the patient's perception of their swallowing functioning. For example, the 10-item eating assessment tool, the Eat 10. Conduct a complete oral motor exam, then work through the cranial nerve exam. Administer standardized screening protocols such as the 3-ounce water swallow test and the Yale swallow protocol, as appropriate depending on your setting and the medical complexity of your patient. Next, you can administer PO trials. Sometimes you may already have an idea after your chart review and talking with the patient that video fluoroscopy or fees is indicated, and PO trials are necessary because they won't change your plan of care. During the PO trials, you will be looking at things like labial seal, anterior spillage, and evidence of oral control, including mastication in transit, manipulation of the bolus, presence of hyolaryngeal excursion as observed externally or to palpation, which can't always be reliable at bedside, and time required to complete the swallow sequence. Beyond the actual motor movements of chewing and swallowing, you will also be looking for behavioral signs and symptoms, such as throat clearing or coughing before, during, and after the swallow, which may not always be indicators of penetration and/or aspiration. The impact of fatigue and/or respiratory function on swallowing. Are they pausing often to catch their breath? Does their respiratory rate increase during or after PO trials? Look for changes to physiological status, vital signs, and voice quality, and the patient's use of additional equipment as appropriate, like adaptive drinking cups or straws. It's not uncommon for an SLP to redirect the plan of care or guide the team on a new diagnosis because of the findings during the cranial nerve exam, oral motor exam, or clinical swallow evaluation. SLPs aren't just looking at the swallow and whether or not there's concern for aspiration. We're closely looking at the entire person. I've even noticed that a cranial nerve exam didn't match up with the patient's case history, or I've noticed a change in motor or sensory function that triggered a discussion with the medical team in neurology. I know I advocate often for instrumental swallow studies, but this doesn't mean there's no value in the clinical swallow exam. Far from it. This is a critical first step in putting all the puzzle pieces together for our patients. I've got a bonus for you. If you want an example of a CSE, click the link in the comments and description to see a video demonstration of the clinical swallow evaluation from the MedSLP Collective. Now that we've covered how to assess dysphagia, you might be wondering, okay, how do I actually develop a therapy plan after video fluoroscopy or fees? Got you covered. We're about to dive into all things dysphagia treatment. Don't forget to stick around until the end of this video. If you're an SLP who could use some help picking out the exact dysphagia exercises that will help your patients the most, then you're going to love the freebie I have for you. Video fluoroscopy and/or fees. We cannot diagnose what we cannot see. Now, the ASHA Practice Portal, which has gotten way better if you haven't checked it out lately, states that an instrumental exam is indicated when the following is identified: concerns regarding the safety and efficiency of swallowing function, disordered swallowing physiology to guide management and treatment, the need to assist in the determination of a differential medical diagnosis related to the presence of dysphagia, the presence of a medical condition or diagnosis associated with a high risk of dysphagia, previously identified dysphagia with a suspected change in swallow function, and the presence of a chronic degenerative condition with a known progression, or the recovery from a condition that may require further information for the management of oropharyngeal functioning. How can you decide between fees versus video fluoroscopy? If you haven't already, make sure to check out another video on my YouTube channel where I dive into the differences between video fluoroscopy and fees and what to consider when deciding between the two. In the meantime, here's a quick recap. Let's start with fees. Here are the basic cliff notes of what fees is, some pros and cons, and what it can be used for. Fees uses a flexible nasoendoscope that's passed through the nose and into the throat while the patient is awake and alert. The endoscope connects to a monitor to view the superior larynx and pharynx. Fees assesses the pharyngeal phase of the swallow. Fees is portable equipment, which means it can be completed at the bedside. There is no exposure to radiation, so it can be an alternative to the video fluoroscopy. Fees does not use barium, it uses real food instead, and you are not under time constraints like you would be with radiation. Fees allows for assessment of laryngeal function and vocal fold movement. It gives us full color images, unlike video fluoroscopy, and can be used to assess secretion management. Now let's move on to some quick points about video fluoroscopy. This is a fluoroscopic video swallow study to assess oral, pharyngeal, and esophageal swallow function. It allows us to view oral cavity, trachea, nasal cavity, larynx, pharynx, esophagus, and the cervical spine, which is great for C-spine fractures, spinal surgeries, or ACDFs. We can screen for esophageal disorders during a video fluoroscopy. It's completed by an SLP and a radiologist. It can be used for patients on sinus precautions or who may not tolerate being scoped for fees. The patient will drink barium, not actual food or drink items. And using this information, you can decide which might be best for your patient if you have access to both. The best possible scenario would be to complete both the video fluoroscopy and fees to give you a complete picture of the swallow. However, this is definitely not necessary or possible for a lot of SLPs or their patients. If you do have access to both, considering things like the patient's anatomy, tolerance to being scoped, transportation limitations, and specific swallowing components you want to assess, like the esophageal phase or secretion management, this can help you make the best decision for your patient. There are so many wonderful examples of SLPs guiding a proper diagnosis through either video fluoroscopy or fees or both that could not have been possible without those instrumental exams. We get a lot of excellent case studies inside the collective as well. Stories that involve catching diverticuli, esophageal impaction, a fistula, atypical growths, some of which have been malignant, and even rare cases like dysphagia lusoria, which is a type of dysphagia that results from a rogue subclavian artery that wraps behind the esophagus and compresses it, sometimes causing food to get stuck or slowly empty. Exercise, compensations, family patient education, or a combination of all of these. There is no one way to manage dysphagia, but there are a handful of main categories we'll discuss in this section: exercise, compensations, patient-family training, and comfort-focused care. Sometimes our therapy approaches will take a little bit from each category. Dysphagia exercises. The purpose of dysphagia exercises is to rehabilitate. How do we choose what exercises to use? Based on the physiological impairments from video fluoroscopy or fees, the patient's diagnosis, is it acute or progressive, what can they tolerate, and the patient's goals. For example, if your patient has poor oral containment due to lingual weakness, you may choose to use a tongue press or a tongue strengthening device. There are countless stories in the collective of patients being NPO for months, completing an intensive exercise program such as effortful swallows or MDTP, and returning to PO. One SLP shared a story about working with a teenager who was involved in a motor vehicle accident and went to an LTAC while remaining NPO with a PEG and trach and no SLP intervention. When he arrived at her rehab facility, she was able to get a fees done, which showed tons of silent aspiration and an inability to clear his secretions. She used the findings from her instrumental swallow exam to come up with a therapy plan, which included 2 weeks of dysphagia therapy twice a day and incorporated neuromuscular electrical stimulation, intensive dysphagia exercises that targeted specific muscles, and sensory stimulation. When she did a second fees exam, he didn't show any aspiration with liquids and purees. He couldn't clear solid foods, but they were able to start him on a modified diet, which motivated him to just keep working. This patient even told his SLP that he never thought he would be able to do anything ever again after the accident. But now that he was eating and drinking something again, he was eager to see how much more improvement he could make in other areas as well. Compensatory strategies are for patients who do not have a rehab potential, for example, if they have a degenerative disease. We can use strategies to compensate for the deficits noted on imaging. Compensatory strategies can also be used in conjunction with rehabilitative exercises. Examples of compensatory strategies include postural strategies and adaptive devices like liquid through a straw, spoon, or slow flow cup. SLPs can also implement techniques to enhance oral sensation and swallowing maneuvers and recommended modified liquids or diets. Now let's look at family patient training and comfort-focused care. The purpose of this level of training is to support patient and family wishes. This is always the goal, really. If the patient does not want therapy or further intervention, we can offer education and support if they ever need you in the future, on compensatory strategies, home exercise plan, whatever the patient wishes. If the patient is at end of life, the SLP's role is to support the patient and family wishes. Does the patient want food or drink for comfort purposes? Does the family need training to help offer food and drink for comfort to a patient with dysphagia? Counseling is another role SLPs will take on, and it's within our scope of practice. According to ASHA, part of the SLP role involves counseling individuals, families, coworkers, educators, and other persons in the community regarding acceptance, adaptation, and decision-making about communication and swallowing. Counseling is not rescuing the client from their problems, telling your client what to do, stating what's wrong with the client, or memorizing rote responses for each client. It is a process that helps patients explore and clarify their thoughts and feelings so they may see difficulties more objectively and make their own decisions, according to Parkinson's and Ray. If you'd like to learn more about dysphagia exercises that correspond to different physiological impairments, make sure you go to www.medslpcollective.com and access your free MedSLP clipboard kit. More specifically, check out page 54 of the clipboard kit. And if you'd like to join a community of MedSLPs from around the globe to share questions, challenges, and continue to grow your clinical knowledge, then I invite you to enroll in the MedSLP Collective by going to the link in the description below.